Welcome back. Let's continue our journey into mental health principles. When responding to a mental health emergency, scene safety is absolutely paramount, even more so than on a typical medical call. The patient's behavior may be unpredictable, and there could be potential dangers in the environment. Your safety comes first. If dispatch or bystanders report any violent behavior or weapons, like a knife, gun, or even improvised weapons, do not rush in. Stage a little distance away and wait for law enforcement to declare the scene safe. It might feel wrong to wait when someone is in crisis, but remember, if you get hurt, you cannot help the patient at all, and you'll create an additional emergency for responders to manage. Always err on the side of caution with psychiatric emergencies. If things look potentially dangerous, request police backup early. In many areas, police automatically respond to behavioral emergencies for this reason. As you arrive, start observing from a distance. Take a moment, even if it's just a few seconds, to look at the big picture. Is the patient agitated, pacing, or lying still? Are they yelling or quiet? Do you see bottles of alcohol or pill bottles around? Are there other people present who look upset or injured? Are there indications of a struggle, overturned furniture, broken glass? This quick scan can give you valuable information about what's going on and what might have caused the crisis. It also helps identify any hazards, like weapons or dangerous objects, that you'll want to steer clear of. When you do approach the patient, think about positioning and body language. A good practice is to approach at an angle and not within arm's reach until you've assessed stability. Why 45 degrees? If you approach head on, some people might perceive it as confrontational, like you're squaring off with them. Approaching from the side is less threatening. Plus, standing off center can protect you. It's easier to step back and creates a bit of a buffer if the patient suddenly becomes aggressive. Keep your hands visible and posture relaxed, but ready to move if needed. Also, make sure you have an exit path. Don't corner yourself in a room if the patient is between you and the door. Now, on initial contact, a calm introduction can set the tone. Speak softly and in a caring manner. For example, "Hello, my name is Megan and I'm a paramedic. I'm here to help you out." This simple statement does a few things. It identifies you as a helper, not a threat. It's respectful, and it opens the door for communication. You'd be surprised how often a gentle introduction can lower the temperature of a tense situation. Avoid sudden movements, loud noises, or approaching too fast. Those can startle the patient or make them defensive. Finally, work as a team. Often you won't be alone. You might have a partner, additional EMS crews, or police officers on scene. Before directly engaging the patient, quickly huddle with other responders if you can. Decide who will be the primary communicator. Usually, one person should do most of the talking to avoid confusing the patient. Plan what each team member will do if the patient suddenly becomes combative or tries to run. Nonverbal signals or a code word can be handy if you need to indicate to your team to move in or back out. A coordinated team approach looks and feels more controlled, which can in turn help the patient feel more secure. The key is, don't overwhelm the patient with too many people talking at once or barking orders. One calm voice should take the lead and others assist as needed. At this stage, we haven't even begun medical treatment, and that's intentional. The way you enter the scene and establish safety lays the groundwork for everything that follows. If you come in carefully and thoughtfully, you're setting yourself and the patient up for a better outcome. Once the scene is safe enough to approach, it's time to assess the patient, and this includes both their medical condition and mental status. In a behavioral emergency, your assessment is really twofold. Make sure there isn't an underlying medical problem causing or contributing to the behavior, and evaluate the person's psychological state so you can communicate that to hospital staff. Start your assessment from a slight distance if possible. As you approach, you can begin noting important things about the patient's condition. Are they alert and looking at you or not noticing you at all? Are they moving around, twitching, or lying very still? Do they respond when you speak to them? This is essentially checking their responsiveness. For example, if you walk in and say, "Hello, can I help you?" and they look at you and answer, they're at least alert to your voice. If they don't acknowledge you at all, they might be in their own world, perhaps in a psychotic episode, or have a decreased level of consciousness. That quick observation helps you decide your next steps. Next, never forget the basics, the primary survey. Even if someone is screaming or acting bizarre, they are still a human that needs air, blood flow, etc. Ensure the airway is open. This might simply mean looking to see if they're talking clearly, which generally implies an open airway. Check breathing. Are they breathing too fast, too slow, or not at all? Check circulation. Do they have a pulse, any major bleeding, skin color and temperature, etc.? Most of the time in a psychiatric crisis, ABC issues aren't the cause of the behavior, but sometimes a medical emergency is masquerading as a behavioral one. For example, a person acting lethargic or drunk might actually be hypoglycemic. If the patient is not cooperative, you may have to do as much of this primary check as you can from observation or when you get a brief window of cooperation. A crucial principle: assume there might be a medical cause until proven otherwise. Many EMS protocols say to treat any unusual behavior as a possible medical emergency, so look for those clues. Low blood sugar. If you have a glucometer, check the glucose level for any altered mental status. Hypoglycemia can cause confusion, sweating, even combativeness, and it's easily treated. Hypoxia. Use pulse oximetry if you can. Hypoxia from conditions like COPD or even a pulmonary embolism can cause anxiety or confusion. If in doubt, give oxygen. Intoxication or overdose. Look at pupils. Pinpoint could mean opioid overdose, dilated and agitated could mean stimulants. Sniff for alcohol, check for medication bottles or drug paraphernalia around. If you suspect an opioid overdose, naloxone might be life-saving. Head injury. Is there any sign of trauma? A bump on the head or bruises? If the setting is unclear, like the person was found on the ground, consider a fall or injury that might have caused a brain insult. Stroke or neurologic issue. Uneven pupils, one-sided weakness, or garbled speech might indicate a stroke rather than a primary psychiatric issue. In short, run through the mental checklist often taught with altered mental status, sometimes abbreviated AEIOU tips: alcohol, epilepsy, seizures, insulin, blood sugar, overdose, oxygen, uremia, kidney failure, or underdose, trauma, infection, psychiatric, stroke. This helps ensure you're not missing a treatable medical problem while focusing on the psychiatric. Now, concurrently or after checking the immediate medical stuff, you want to assess the mental status more deeply than you normally might in a trauma, for example. Paramedics use a mnemonic coast map to remember key components of a mental status exam. Consciousness, level of consciousness. We did this with AVPU essentially. Orientation. Does the person know who they are, where they are, the date, time, and what's happening? You might ask, can you tell me your name? Do you know what day it is? Do you know why we're here today? This checks orientation times 4. Person, place, time, event. Activity. What are they doing? Are they restless, pacing, sitting calmly, or curled in a ball? Activity level can indicate agitation versus depression, for instance. Speech. Listen to how they talk. Is it rapid and pressured? There are words pouring out quickly? Is it slow and mumbled? Do they make sense? Or is it word salad, or nonsensical combinations of words? Speech can tell you a lot about their thought process and mood. Thought. This is about the content of their thoughts. Are they expressing paranoid or bizarre ideas, like, the TV is controlling my mind? Are they fixated on something? Do they appear to be hallucinating, like talking to someone who isn't there? You might not directly know their thoughts unless they speak them, but observe for signs like responding to internal stimuli, turning to look at things that aren't there, mumbling to themselves. Memory. It might be hard to formally test memory in the field, but you can gauge if they remember recent events. For example, do they remember what happened earlier that day or what they were doing before you arrived? If they seem extremely confused about the recent past, that could point to something like a neurological issue or severe disorientation. Affect and mood. Affect is the external expression of emotion, what you see on their face and in their tone, and mood is the internal feeling they report. Do they appear depressed, flat affect, tearful, anxious, wringing hands, wide-eyed, or manic, euphoric, overly energetic? Sometimes you can ask, how are you feeling right now? To get an idea of their mood and compare that to what their affect looks like. Perception. This ties into hallucinations or misperceptions. Are they perceiving things accurately? If someone is hearing voices or seeing things, that's a perceptual disturbance. They might also misperceive you as a threat when you're not. That's important to recognize so you can reassure them. As an EMS professional, you might not formally write down all these categories, but being mindful of them ensures you do a well-rounded assessment of the person's mental state. Importantly, you'll convey these observations to the hospital staff or mental health professionals. It helps them immensely to know, for example, the patient is alert and answered questions, but speech was very rapid and disorganized, and he seemed to be talking to someone not present. While assessing, try to get some history if the situation is calm enough. A few key pieces of information. Psychiatric history. Does the patient or family mention any known mental health conditions? Have you ever been diagnosed with any medical or psychological condition? Maybe they have a history of schizophrenia, or they were hospitalized for mental health before. Or maybe no history. This could be the first episode, which is useful to note. Medications. Do they take any medications for mood or mind, like antidepressants, antipsychotics, anxiety meds? Or any medications at all? Sometimes steroids or other drugs can affect mood. If you find medication bottles, bring them along to the hospital. Substance use. Has the patient been drinking or using drugs? When did they last use? How much? If the patient won't say, ask family or look for evidence. This helps differentiate if what you're seeing could be substance induced. Recent events. Did something happen that precipitated this? Did they have a major loss, argument, or trauma? Even something like he's been under a lot of stress at work can be a clue. If the person is suicidal, ask if something specific made them feel that way today. Medical history. Don't forget general medical history too. Do they have diabetes, seizures, or anything that could cause sudden confusion or weird behavior? When asking questions, use a gentle, sympathetic approach. This is where reflective listening is golden. For example, if a family member says he's been really stressed since he lost his job, you might respond, I'm sorry to hear that. Losing a job can be extremely hard. I understand he's been under a lot of stress. Repeating or rephrasing what someone tells you shows you're listening and empathizing, which builds trust. With the patient directly, you might say, it sounds like you're feeling really scared right now, if they're expressing fear. This can help the patient feel heard and possibly open up more. Throughout the assessment, maintain rapport. The patient is more likely to cooperate with your exam, like allowing vitals or blood sugar checks, if they feel respected and heard. Sometimes you have to get creative. For instance, if they're afraid of your blood pressure cuff, maybe hold off until they're calmer or explain in simple terms what you're doing and why. This is just a blood pressure cuff. It will squeeze your arm for a few seconds. It won't hurt you. Is it okay if I check? By the end of this assessment phase, you want to have addressed any immediate medical needs, like giving glucose if needed, oxygen, etc., formed an initial impression of the person's mental state, and gathered any critical background information. This sets you up for deciding the next steps in management and transport. Good communication is perhaps the most powerful tool you have in a mental health emergency. Sometimes just the way you talk and listen can de-escalate a crisis better than any medication. Let's go over some key communication techniques. First, use open-ended questions to get the conversation started. Instead of asking something that can be answered with a simple yes or no, invite the person to express themselves. For example, can you tell me what's going on today? How are you feeling right now? And help me understand what you need or what you're afraid of. These kinds of prompts give the patient an opportunity to share their story or feelings in their own words. It also gives you valuable insight into their mental state. Maybe they'll say, I feel like everyone is out to get me, which clues you into paranoia, or I just can't take it anymore, which hints at possible suicidal thinking. The goal is to let them vent or explain rather than you doing all the talking. While they speak, practice active listening. Show them that you're engaged in what they're saying. This can be as simple as nodding your head, saying, uh-huh, or I see at appropriate times, or repeating back a bit of what they say. For instance, if the patient says, I just lost my job and I'm so stressed, you might respond, you lost your job, and that's causing a lot of stress. That technique is called reflective listening. You mirror what they've said. It not only clarifies that you heard them right, but it also makes them feel understood. Express empathy for their feelings. Phrases like, I'm sorry you're going through this, or that sounds really tough, can validate their emotions. If a patient feels acknowledged, this EMT gets that I'm in pain or afraid, they often become less agitated and more cooperative. Even if you can't solve their problem, knowing someone cares and is trying to understand can be very soothing. Maintain a calm and non-judgmental tone throughout. No matter what the patient says, even if it's something shocking, bizarre, or offensive, try not to show shock or judgment on your face or voice. Keep your voice steady at a normal volume or slightly lower. Speaking a bit more slowly can help if someone is really agitated. They'll often start to match your calm tone subconsciously. Avoid medical jargon or technical talk. Use simple, reassuring language. For example, instead of, we need to transport you for a psychiatric evaluation, you might say, we're going to take you to a safe place where a doctor can help you feel better. Importantly, do not argue with the patient, especially if they are delusional or misinterpreting reality. If a patient insists, the government planted a chip in my brain, you're not going to be able to talk them out of that belief in the moment. Arguing will just build a wall between you. Instead, you might say something like, I don't see evidence of that, but I know you're really worried about it. You're safe with us, and we'll make sure you get help for what you're feeling. You're not confirming the delusion, but you're also not dismissively arguing. The same goes for a patient who is extremely angry or saying hurtful things. Don't take the bait and argue back or get defensive. Keep bringing the focus back to helping them. I hear that you're angry. I'm here to help, not hurt you. Your body language also communicates volumes. We touched on some of this in scene approach, but during your interaction, continue to be mindful. Try to appear relaxed and open. That means unclench those fists, Keep your arms uncrossed, maybe keep your palms up or just at your sides so they can see you're not hiding anything or clenching. Use an open stance and give them some personal space. Eye contact is a tricky balance. You want to make enough eye contact to show you're paying attention, but not so much that it feels like you're staring them down. If the patient looks away or seems paranoid, it might help for you to occasionally look away too so they don't think you're fixed on them. If the patient is seated or on the floor and it's safe to do so, consider getting down to their level, like sitting on a chair or kneeling a few feet away. Standing over someone can feel intimidating, as if you're asserting power over them. Be patient and embrace silence when it happens. Silence can actually be a therapeutic tool. For instance, if you ask an open question like, "What are you hoping we can do for you right now?" the patient might pause, thinking, or maybe they feel overwhelmed. Instead of immediately following up or rephrasing the question, give them time. Sit quietly, maintaining a caring expression, maybe nod encouragingly. Silence can feel uncomfortable, but resist the urge to fill it with more chatter. People in crisis sometimes need extra time to process their thoughts or overcome paranoia to answer you. If they're not speaking at all, you can every now and then gently prompt, "I'm here when you're ready to talk," but don't badger them with repeated questions. Another tip: keep stimuli low. For example, if your radio is blaring or lots of people are talking nearby, try to reduce that. Too much noise or commotion can worsen confusion or agitation. In summary, good communication is about making the patient feel heard, safe, and in control as much as possible. You're establishing a human connection. You'd be amazed at how often a person's escalation will diminish just because they feel someone is genuinely listening and cares about their well being. So, we will wrap up this lecture here. See you on the next one.